Hello, welcome back to Integrated Clinical Vignettes with Dr. Carlo Raj. We'll continue our discussion with our 74-year-old patient from last week. When we looked at that ECG, we were unable to properly identify distinct P waves. The QRS complexes that then showed up shared no correlation with the P waves. And when the QRS complexes did appear, they were irregular. In developed countries such as the United States, we said that the cause would be most likely of cardiac origin. And remember, please, that I will give you the most likely issues or the most likely triggers. Etiology: hypertensive heart disease, coronary arterial disease, and if it is in developing countries, then more likely to be rheumatic heart disease. Always understand as to where you're located, where your patient's coming from, and then ultimately put all the clues together so that you're able to properly come up with a workable diagnosis. So with this type of history, we said that most likely issue here was atrial fibrillation. And we said that if there was atrial fibrillation, then this would predispose your patient to develop thrombi in the left atrium and therefore resulting embolization. Most notably, maybe carotid artery resulting in a stroke, maybe perhaps the intestinal arteries resulting in ischemic bowel disease, an absolute emergency where all of a sudden the bowel sounds are going to disappear and you're worried about rupture and peritonitis and such. Now, the term irregular, if you were to see that wherever it may be, on boards as a question, on your chart, you should be thinking about a couple other differentials. Keep in mind that it's all of the clues that you want to bring in together. And so therefore the irregular pattern, multifocal atrial tachycardia, irregular type of pattern. However, the origin of that type of pattern would be most likely pulmonary in nature. Another differential for irregular type of pattern on ECG is premature atrial contraction. Here, the triggers might be something like caffeine. How often do you drink coffee? And if you do, especially as a medical student, as a doctor, perhaps like me, you drink it, well, probably more frequent than you would drink water. Stimulants. You get the point. Now, since we've talked about this being irregular, well, that's not going to help you. Yeah, maybe it gives you a few differentials, but obviously you need to pay attention to the ECG. With multifocal atrial tachycardia, understand that the P waves here are undergoing morphologic changes and then you develop a QRS complex. And what kind of changes could they be? Maybe step-like manner, maybe up or down, and then a QRS complex. This type of vacillating P wave, quote unquote, is not present in atrial fibrillation. Fibrillation is that either there's really indistinct P wave, but you still remain around the isoelectric line. Multifocal atrial tachycardia, pay attention to pulmonary disease. Maybe theophylline therapy. Premature atrial contraction, as the name implies. You will find P waves preceding the QRS complexes, but please understand those P waves are appearing abundantly, or lack thereof. Could be distinct, but these are premature contractions that are taking place. Premature atrial contraction. Alright, so those are some important differentials that you might be thinking about if you were identifying a description such as irregular. But what if it was regular? What if you were able to conclude that the pattern here was regular? Maybe atrial flutter. Atrial flutter would be something that you would find P waves, but the P waves would be in a sawtooth type of appearance, wouldn't it? Irregular. Could be irregular, occasionally, depending as to AV conduction. Cardiac disease. The flutter waves, well, usually 2-to-1 type of ratio. Other types of regular description or patterns of tachycardia arrhythmia would be AV nodal reentry. Maybe you're thinking about Parkinson-White syndrome, in which you have an accessory pathway. So therefore, the PR interval in that particular case would be shortened. So those are regular, right? Irregular. Now, coming back to our patient, well, we noticed that the toes were blue. When I say the toes were blue, I don't mean that it was a bruise. It was almost gangrenous in nature, wasn't it? If you take a look at it. And so therefore the differentials, or the answer choices that we had, begin with Achenbach. So what is Achenbach? That was our first answer choice. Is it the correct answer? Is it relevant to our patient? Is it the possible diagnosis of the toes? Are these the changes that you'd expect? Well, let's talk about Achenbach, shall we? And Achenbach, well, it's a elderly patient. Maybe a female. Okay. So for the only difference is the gender. We'll call it a male, perhaps. But, now, what does that mean? What are you looking for? What are you looking for? The digits, huh? And by digits, I mean let it be the toes or the fingers, whatnot. And it's really the volar aspect. Right? So if it's the volar aspect of the hand, then you're thinking about the palmar aspect. But what part of your hand? Is it the palm? No. It's the pads of your fingers. Are you touching them? Touch them. Feel them right now. Huh? They're the pads of your fingers. Maybe the pads of the toes. But it's the sudden onset. It'll appear as being blue. No doubt. Looks like a bruise. May appear as being cyanotic. How does this take place? But understand that here, actually, we can't understand because the etiology is rather idiopathic. But the triggers are interesting. It's sudden onset. Maybe your patient was taking migraine medication, such as ergotamine. And if you do your labs will come out to be perfectly normal. So something that you want to keep in mind if your patient comes in with something that looks like a bruise, something that looks like it's cyanotic. It's not Raynaud's disease. It's not vasospasms. It's not issues in which there is ischemia taking place. No. It is the sudden onset of pain, and there's complete resolution spontaneously. So the fact that you see or read such a description of a patient, well, it's not relevant to what is taking place with ours. Ours, well, our patient had atrial fibrillation, thrombi formation, and what then caused, especially after giving therapy prophylactically to then prevent what? Those thrombi formation. What might you be even thinking about giving prophylactically? A quote-unquote blood thinner, so that you do not develop that thrombi, so therefore you would never, hopefully, develop those emboli. How about warfarin? You might be thinking about warfarin, aren't you? Especially where? Outside the hospital. Okay, so keep that in mind. Achenbach, what do you think? Likely or unlikely? Let's move on.